Welcome, and thank you for joining us. My name is Dean Lee, and I am Professor of Physics at the Facility for Rare Isotope Beams, or FRIB. Today's public talk is part of an initiative at FRIB called the Advanced Studies Gateway. The goal of the Advanced Studies Gateway is to inspire people. We bring together researchers, innovators, creative thinkers, artists, and performers from all fields and strengthen ties between Michigan State University and the community. Today, we have the pleasure of presenting a public lecture by Dr. Emery Brown entitled Deciphering the Dynamics of the Unconscious Brain Under General Anesthesia. Dr. Brown is the Edward Hood Kaplan Professor of Medical Engineering and Computational Neuroscience at MIT, the Warren M. Zappel Professor of Anesthesia at Harvard Medical School, and an anesthesiologist at Massachusetts General Hospital, or MGH. He received his PhD in statistics from Harvard University and his Doctor of Medicine degree from Harvard Medical School. Dr. Brown completed his internship in internal medicine at the Brigham and Women's Hospital and his anesthesiology residency at MGH. Dr. Brown is an anesthesiologist and statistician whose research is defining the neuroscience of how anesthetics produce the states of general anesthesia. He also develops statistical methods for neuroscience data analysis. Dr. Brown is a fellow of the IEEE, the American Association of the Advancement of Science, the American Academy of Arts and Sciences, the National Academy of Inventors. He is also a member of the National Academy of Medicine, the National Academy of Sciences, the National Academy of Engineering, and the American Philosophical Society. Dr. Brown has received an NIH Director's Pioneer Award, an NIH Director's Transformative Research Award, the Sachs Prize from the National Institute of Statistical Science, a Guggenheim Fellowship in Applied Mathematics, the American Society of Anesthesiologists Excellence in Research Award, the Dickson Prize in Science, the Swartz Prize for Theoretical and Computational Neuroscience, the Pierre Galetti Award, the Gruber Prize in Neuroscience, and Doctors of Science honoris causa from the University of South California and SUNY Downstate. If you have any questions during this talk, please type them into the chat or the question and answer dialog box. At this time, it is my great pleasure to introduce Dr. Emery Brown.
Great. Dr. Lee, thank you very much for that kind introduction. Also, thanks for the opportunity to speak with the public here today. As mentioned, I'm going to talk about deciphering the dynamics of the unconscious brain under general anesthesia. I don't know what concept you have of anesthesia right now, but you might think the brain is turned off. It turns out it's not turned off. It's actually quite active, and that's what I want to explain today. So these are the funding sources that I've had the good fortune to enjoy from NIH, from my departments at MGH and MIT, and also I just mentioned some personal financial interest that I have in some of this work. So this is the outline I'm going to follow. I'm going to give you a clinical look at general anesthesia, and then we'll talk about loss of consciousness induced by propofol and other anesthetics. We'll talk about anesthesia in the aging brain, how it changes with age, the effects we can see. And also I want to talk a little bit about the future, closed-loop control and reanimation from general anesthesia. So here are the main points that I'm going to make. The brain under general anesthesia is dynamic. It's not turned off. One of the primary ways through which anesthetic create altered arousal states is by inducing and sustaining oscillations. These oscillations are readily visible in the EEG and change systematic with anesthetic, age, and the state of patient's health. And actively turning the brain on after general anesthesia may be a way to speed recovery and reduce postoperative cognitive dysfunction. Brain dysfunction after anesthesia is fairly common, and it's particularly common in elderly patients. And so general anesthesia is also an underutilized paradigm for studying the brain. All right. So let's start with the definition. What is general anesthesia? It's a drug-induced reversible state that consists of antinociception, unconsciousness, amnesia, akinesia, and maintenance of physiologic stability. This term up here, antinociception, may not be familiar to you, but if you're unconscious, normally you might be inclined to say analgesia. But analgesia refers to pain, and pain is a conscious processing of something that hurts. But under anesthesia, you're unconscious, but your pain systems still work. And so what you have to do is still turn them off even though you're unconscious. That's why we say antinociception. And it's critical that this be reversible because these conditions here would be synonymous with death otherwise. And it's often said that it's not clear how anesthesia works, but nothing could be further from the truth. I hope to dispel that myth by the time we finish this lecture. I just want to go through a modicum of history, though. So the first public demonstration of ether anesthesia took place at Mass General Hospital back in October 16, 1846. It was done by William Morton. And Morton was a dentist who at the time had a way of, he figured he could build a nice set of dentures for patients if he could take out all their teeth. And dentists, like surgeons, were measured by how fast they could work. He could take out a tooth in a minute. So he stumbled upon ether as a way to, the term anesthetize didn't exist at the time, mesmerize patients so that they could tolerate this procedure that he was going to do on them. And he tried it on himself and, was convinced that it would work. So he proposed this to a surgeon at Mass General Hospital, John Collins Warren. And on October 16th, 1846, in the Ether Dome at Mass General Hospital, they did the first public demonstration of ether as an anesthetic. And he had a flask, these glass flasks, and he had a sponge inside soaked with ether. And he held it up to the patient's face and let him breathe it in. And he became unconscious. And he told Dr. John Collins Warren, "Your patient is ready, sir." And he was able to perform the surgery. And afterwards, this was a comment by Dr. Warren that this was no humbug. I mean, this really worked because they tried something similar the year before with nitrous oxide and it hadn't worked. So Morton realized he had figured out something big. So he wrote to this gentleman here, Oliver Holmes Sr. He's the father of the Supreme Court Justice. And he's the person who coined the term anesthesia from the Greek anesthesia, meaning lack of sensation. He said the adjective would be anesthetic. And to give you some idea, so this was the fall of 1846. Basically by December and January, it had spread, to England and to Europe. And so this was a major change in medical practice, because prior to that time, surgical research centered on how do you strap people down. Now I could actually focus on, the operations themselves and do operations aside from just amputations. So this was a big advance. So how do we actually do it now? So we pre-medicate you with some drug, let's say like fentanyl or midazolam, opioid or a benzodiazepine, and just to sort of calm the patient down initially. Then we'll do an induction with propofol, which we'll talk a lot about today. Very well, it's always in the news quite a bit, unfortunately, because of what happened to Michael Jackson. And the inhaled drugs that I'm referring to here are also ethers. I mean, we still use sevoflurane, isoflurane, and desflurane. They're ethers. Then to maintain anesthesia, we could use one of the ethers, propofol, or an opioid such as hydromorphine. And then to make sure that your muscles are relaxed and it's easy for the surgeons to operate, we give you an anticholinergic drug, which relaxes the muscles. So you can see you have a very, very large combination of drugs, just even for a simple operation. This is called balanced general anesthesia, using different drugs to try to achieve the state you want. Because if you use just a single drug, let's say like the ethers by themselves, you would end up with much more side effects, particularly hypotension and sort of cardiac depression. So let me just show you what this looks like. So we put EEG on our patients, 4 leads, and this is a woman I took care of. It's been over 10 years or so ago now, and she's going to have a thyroid surgery. And she's about 60 years of age. She weighs about 80 kilograms. And I'm going to give her 150 milligram bolus of propofol. This is a very standard dose. We're just going to watch how her EEG changes. So see the 4 leads. Now it's going to get very noisy here because propofol is injected into a small vein. It burns like you're going to see her EEG really noisy. That's actually going to be good for her. Now watch right here. Yeah, you can see it now. It's really bothering. And we let them just breathe through it. It'll grow and grow. In about another 6 or 8 seconds, watch it happen. Just the exact one to drop. Watch right here. Beta oscillations, they get deeper. Low oscillations, which get even deeper. So she's out, she's become unconscious right there. And then they're gonna go flat, and then burst, and then flat, and then. So what have I just shown you here? So this is her when she started out with, maybe an EEG, which is about 5 microvolts. So this is the sort of oscillations we typically generate that are observed when we're just carrying on normal sort of brain activity, communication, what have you. And so this is about 5 microvolts. And then we saw her go down to this state here, on the very regular oscillations, beta oscillations, which is usually a sedative state. If I wanted to sedate her so that she could have a colonoscopy or something like that, this is the state I would try to achieve and maintain. But then from there, we saw her go, we skipped over this state. We'll come back to that. She went right to this state here, E, where she had just sort of large, slow oscillations. And in this particular case, this is an indication that one of the things that indicates that the brainstem is being inactivated. And we know this from some studies and also in animals, and also just the clinical observations of patients in the operating room. And so she's become profoundly unconscious. And then she went to this state here, burst depression. This is a profound state of unconsciousness. We try to avoid this state because it's more unconscious than someone needs to be. In between the burst, she actually is isoelectric. And this state here, the alpha oscillations, and by that I mean she has slow oscillations, which are about 1 cycle per second. You can see them right there going up and down. Then riding on top of those, you have about a faster oscillation called the alpha oscillation, which is about 10 cycles per second. And that's what we're going to talk most about. And there's another state called paradoxical excitation, which we'll probably get to at the end. In other words, that sometimes, as opposed to going into the sedative state, when patients are waking up, they actually get paradoxically excited. It's paradoxical because these drugs are supposed to sedate you, and they actually excite the patient. The main thing I want you to notice here is, look, here you have very oscillations, which are very low amplitude, high frequency, and they transition down to oscillations, which are very large amplitude at lower frequency. And it's these sorts of dynamics. If you need to be in this state here, in order for the parts of your brain to communicate, these states here are so far away that it's very hard for the parts of the brain to communicate. So we think the oscillations are part of the mechanism to which the drugs are inducing unconsciousness, and they're not an epiphenomenon. There are other things that are happening too, but this is one of the biggest phenomena that we'll see. So we're going to talk a lot about the oscillations today. And just to show you this from another perspective, so in the operating room, we look at this in terms of the spectrogram. So in other words, we look at the breakdown of the oscillations as a function of time. So this is time on this axis here. Here's frequency here. And this is a young woman I took care of a few years back. She was having a short procedure. And so right here, I gave her a bolus of propofol. So you can see that you can read the frequency. So it's between about 0.1 and about 4 hertz here. And that's this here, this oscillation here. And then it switched over. We saw the alpha oscillation come on along with the slow oscillation. All right. And you can see you can see the 10 hertz oscillation riding on top of the slower oscillation, lower frequency oscillation between 0.1 and 4 hertz. And so this is it over time. The color tells you how strong it is. So she has an oscillation at about 10 hertz and one which is between about 0.1 to 4 hertz. And this is a classic signature of propofol. Anytime you give propofol to a young person, this is what you're going to see. And this isn't an enhanced figure or anything like that. It looks exactly this clear in the operating room. And then right here, you turn off the propofol, the oscillations eventually go away and she wakes up over here. So this is what we track in the operating room to make sure that someone is unconscious. We can see this in what we call the spectrogram. It breaks the signals down by their frequency content. So these are my colleagues that I've done this work with: Shannon Ching, who's now a professor out at WashU, Patrick Perd, who's now at Stanford, Nancy Capella, a colleague at Boston University, Ahmad Eskandar, a neurosurgeon who's now at Einstein, Eric Pierce, anesthesiologist at MGH, Laura Lewis, who's now back at MIT as a professor, and Sid Cash, who is one of our neurology colleagues at MGH. Now, before I go into explaining a little bit more about mechanisms, I just want to show you one other bit of phenomenology. I showed you that there's a dynamic through time that you see with the formation of these alpha and slow delta oscillations of propofol. There's another dynamic across the head, which suggests that it's across the entire brain. And that's what I want to show you here now. So what I've done here is, this is someone who had 64 leads of EEG, and I'm showing you 44 of those leads. And up here where I'm pointing up here, this is the top. This is the left ear over here, and this is the right ear over here. And then back here, this is the occipital region, the back of the head. So if you were just to close your eyes and I put electrodes in the back of your head, I can measure what I'd call a eyes closed alpha oscillation. In fact, it's something that pretty much everybody has. It gets weaker as we get older. Maybe about 5 or 10% of people don't produce it. But it's something that electroencephalographers do. They have subjects close their eyes to make sure that, because it's a strong oscillation, to make sure that their EEG setup is working. So this is a volunteer subject that we gave increasing doses of propofol to over a period of an hour, increase for an hour, and then decrease for an hour. And what I'm going to show you is that this oscillation, you can see back here, you can see the 10 hertz oscillation right here, and this big red band right here, and big red band there. As he gets deeper and deeper into the states of unconscious, it's going to move from the back of his head to the front. It's going to move from the back here up to the front. And then when we turn the drugs off and let them wake up, it's going to move back this way. So this says that not only is there oscillations in time, but there are oscillations. There's an oscillatory structure that goes across the whole head, meaning across the entire brain. And so I'm going to play this. So this is baseline, means no drug is working and no drug is running right now. And then I'm going to turn it on, and you'll see the different levels. The highest level is going to be 5. So here, let me just play the video here. So you can see the oscillation in the back there. It's starting to break up a little bit. It's on the first level, so the drug is infusing. You see level 1. So now it really breaks up. And now you see it appearing in the front of the head there. And it's really intense. And it's not even at the highest level yet. 5 is the highest level. There's level 4. See, it's disappeared from the back. It's in the front. Now here's level 5. This is the deepest level. It's quite stable in the front of the head, along with the slow delta oscillation. And now as we turn the propofol off and let them come to level 6, we see it's moved back from the front, and now it's back in the back. So there's a dynamic going across the head, not only in terms of in time, but also across space there. Right? So let's talk a little bit of mechanism. What's going on there? So I can draw a diagram like this. And so propofol works by enhancing what we call GABAergic inhibition. So GABA is an inhibitory neurotransmitter, and it's one of the, and there are neurons all throughout the central nervous system that release GABA, and they act like they use it to sort of control circuits, basically. And so they're all throughout the cortex. I'm going to point out 3 important areas where they are, because they're literally everywhere. But for the sake of this discussion, they're in the cortex here. They're down here in the brainstem, and I'm missing it right here, but they're also here in the thalamus. All right, very important sort of central way station in the center of the brain. And what is it? What happens when propofol binds? Propofol binds and makes these inhibitory neurons that are releasing GABA much more effective. So it actually alters the way that they're controlling these essential networks. Here you can see this is an inhibitory interneuron. It's controlling one of the pyramidal neurons. And then down here, this is a very key region, because, and this is what we saw in the video. See, propofol, when it enters the brainstem, comes up through the basilar artery, which is on the underside of the brain here. And it hits these sites here. These are inhibitory sites which all release GABA. They come out of the preoptic area, the hypothalamus. So you have this just right off the bat. You can see 3 major inhibitory areas, just through the cortex diffusely, and the thalamus here, which again, I'm sorry I didn't put in this diagram, and also here in the brainstem. So you can see where the targets, or principal targets, are for propofol in inactivating or changing the dynamics of the brain. So I can draw a diagram like this. This is what I see in the operating room, and this is what I just showed you. So that when the alpha oscillation comes on, it concentrates in the front of the head, just like I'm showing you here. And what I didn't tell you is highly coherent. That is, if you were to measure the correlation between an alpha oscillation measured here and let's say somewhere else up here, the correlation is 0.8 or 0.9 at the 10 hertz frequency. So it's highly structured. And so what this led us to look into was, could this be something which is the alpha oscillation in particular? Could the alpha oscillation be an effect going back between the thalamus and cortex? So here's the frontal cortex, an area which is very important for conscious processing and reasoning, and then the thalamus, which is basically a way station for everything: sensory information, auditory information, visual information, some motor information goes through there. So if there's one area that, if you could tie it up, which would generate unconscious, is certainly the thalamus. And so what we reasoned was that the alpha oscillation we were seeing is an oscillation going back between the thalamus and cortex. We did that based on modeling studies with Nancy Capel's help initially. Then we actually did some experiments where we stuck electrodes here, and actually showed that that's the case. So you've got this strong alpha oscillation here, which is tying up the thalamus and cortex, and that probably in and of itself would be enough to make you unconscious. But you see, you've got the slow oscillation as well. And let me just tell you a little bit about that. So here's an illustration of it. This is from Lord Lewis's PhD thesis, almost 12 years ago. So we have patients who come to the hospital who have intractable epilepsy, and so they need to have the areas that are responsible for the epileptic seizures resected. They fail medications. So in addition to putting in electrodes to locate where the seizures are, our neurosurgical team and neurology team also implant electrodes to sort of learn a little bit about the brain at the same time. So once the electrodes are implanted, the patient stays in the hospital for 5 to 7 days. They're allowed to cease off of medications. And then they come back to the operating room to have the electrodes removed. Then they'll come back and have they come back to have a resection. So the reason you leave them off the medication for 5 to 7 days, you're trying to sort of locate at least the care team is trying to locate where the seizure foci are. And so when they come back to the operating room to have the electrodes removed, you have a nice natural experiment. All you have to do is just record as you give the patient anesthesia, and you can see how the neurons in the brain and the local field potentials respond to the anesthetic. So here is an illustration of that. So these colors correspond to these locations here over the medial temporal lobe where the electrodes are implanted. And this is a neuron that's sitting next to the red electrode right here. And so this is when the person is conscious. And then look over here. When the person becomes unconscious, there are those large slow waves like I was telling you about, like this whoom, whoom, whoom. You can see they're about every 2 seconds or so. And so now the neuron can spike wherever it wants. See how over here it could spike wherever it wanted to, but now it can only spike at very, very fixed periods. So you have what are called sort of up and down states. And I would submit to you, if this is happening across all the neurons in the cortex, it's going to be extremely difficult for someone to maintain consciousness. So this is just from the slow oscillation itself. And just to show you a little bit more of this, we've done these experiments now also in non-human primates. This is work we did with Earl Miller, who is a primate neurophysiologist at MIT, Andre Bastos, who was his postdoc, and Jake Donahue, who was one of our PhD students. And so these are 4 brain regions. So just to give you a rough idea, so this is kind of written in neuroscience jargon here, but so pardon me for that. So this is 2 areas up in the front. So the prefrontal cortex in area 8A, which is the frontal eye fields. Then 2 kind of posterior areas, so posterior parietal cortex and superior temporal gyrus. So this is going from, let's say, front to back. Just think of it that way. Front's up here, back's back here. All right. So these are the field potentials. Remember, it's usually the low amplitude, not sort of high frequency oscillations with low amplitude. And here are the neurons spiking. So the neurons across the various regions are spiking pretty much wherever they want to. And to give you some, quantify this a bit, they're spiking about 10 to 12 spikes per second. All right. Now here's that same situation where unconscious, where now the animal's under propofol. You see the large slow oscillations. And now look, you see these big bands here where you have no spiking. And they seemingly are coordinated across the entire cortex there. And so now, as opposed to here, the neuron is spiking 10 to 12 spikes per second. Now they're spiking about a half to 1 spike per second. And plus they have these large gaps where there's essentially no spiking. So I don't know how much the spike rate has to drop in order for a person to become unconscious, but I'd submit to you, if this is a state that you see when the slow oscillation is there, the person's not going to be unconscious. So you've got 2 very profound effects that are making someone unconscious under propofol anesthesia. You've got the alpha oscillation tying up the thalamus and the cortex, and you have these general slow oscillations which are operating across the cortex at large. So these are probably 2 of the principal reasons why patients are unconscious under propofol anesthesia. This would be true for other drugs which also work through GABA, such as sevoflurane, the barbiturates, etomidate. So this is what I've just shown you. So how does propofol make you unconscious? So these strong alpha oscillations, which they're tying up the thalamus and restricting communication. The slow waves, which I show you, that sort of create these little islands preventing communication within the cortex or across the various regions. And I showed you this mechanism of anteriorization. And so you can see there's a very strong difference in the dynamic in the front of the head as opposed to the back. So you have all these things happening at the same time. And one of the things that I mentioned sort of briefly is that you also have a very profound effect in the brainstem, sort of the lower part of the brain, and that sends arousal signals up to the cortex and thalamus to sort of keep us aroused or awake or what have you. And by propofol acting also there at the same time, you're taking out the ability for someone to stay awake. So you have all these things which are happening at the same time. So there are multiple mechanisms through which the propofol is making the patient unconscious. But the key thing is it doesn't turn the brain off. It changes the brain's dynamic. So the brain goes from having these, like I said, low amplitude, high frequency oscillations to these very large amplitude, low frequency. So starting with high frequency, small amplitudes, going to lower frequencies and large amplitudes. That's roughly the back of the envelope calculation. If I make no other point today, I want to leave you with this one, which is quite critical. General anesthesia is not sleep. In fact, it's far from sleep. And if you look right here, when you go to sleep, you have like three stages, two main stages, sort of non-REM and REM. So non-REM goes through 3 stages, and then you cycle up to REM. You cycle between non-REM and REM about every 90 minutes or so. You do that about 4 to 6 times a night. And then this is the most profound state of a non-REM sleep, which is like the slow waves. And these are those eyes closed alpha oscillations that I was telling you about before that we looked at when you can record in the back of the head with the eyes closed. And this is just someone awake, just like we were looking at the woman in the video before we started, giving her propofol. And so here, there's a natural dynamic where you go back and forth between the REM and non-REM states every 90 minutes or so, 4 to 6 times a night. So you typically wake up from REM sleep. When anesthesia, what we do is we give you a drug and we hold you in one of these states down here for the duration of the operation. And then we turn the drugs off and you gradually come back to being, awake like here. So in fact, most of the drugs that are on the market for sleep are really, they themselves can't induce sleep. In other words, they can't make you go between REM and non-REM cycling. That would really be a true sleep medication. What they are sedatives, and if you actually refer to some of them as like weak anesthetics, that's actually a much more accurate description of what they do. The idea is they give you just a little bit of sedation, and the hope is then your natural sleep mechanisms take over. But this over here, these states here, even though you see oscillations look similar, they have a totally different structure in them or underlying mechanisms from these over here. So general anesthesia is certainly not sleep. And so we can do this with all the anesthetics, and that's what we've done. So we can see what they look like in the raw signals, but then by looking at the spectrogram, we can get a much better idea of what the structure is, and then start to use that to investigate how these oscillations might be being produced. So this is propofol I showed you before. Here's ketamine. Ketamine's been in the news a lot in the last few years because it's used as a drug to treat depression. And this is actually the pattern that you see when you give someone in the dose range of about 0.5 microgram per kilogram over about 40 minutes or so. This is what you would see. Very high frequency oscillation with ketamine. And then if you were to give a higher dose, it actually go from high frequency to low frequency, high frequency, low frequency. It has this alternation between these two states at about 4 to 10 seconds. Sevoflurane, which is an ether, has a pattern similar to propofol, and in addition, it has an extra oscillation sitting in here, a theta oscillation. And then dexmedetomidine, if you ask me which of the anesthetics comes the closest to generating a state which is best mimic sleep or best approximate sleep, it would be dexmedetomidine, and it approximates like stage 2 non-REM sleep or stage 3 slow wave sleep. So we can then do diagrams just like the ones I showed you before here, and we can try to decipher what we've been doing, trying to decipher through human experiments, rodent experiments, and non-human primate experiments, what the circuitry is that's responsible for the oscillations that we see. So I've used the oscillations to trace down how the drugs are working. Like I said, they're not the phenomenon, they're actually part of the process. So let me show you what happens with age. So these are my colleagues that we've done this work with. So Chuck Birdie, who's an anesthesiologist over at Boston Children's Hospital, Laura Cornelison, who's a postdoctoral researcher there and junior faculty there, Shuna Keiji, who's at Mass General Hospital, he's our chief of anesthesia, Sung-Yoon Kim, who's a postdoc with us, who's now back in Korea as an assistant professor, and Patrick Purdy, who I said is now a professor out at Stanford. So the brain response to anesthesia changes in a very systematic way with age. So this is like the gentleman that I showed you, or the young woman that I showed you is like 19 years of age. You can see the alpha oscillation. This is all going to be propofol, and the slow delta oscillation. So that should look very typical to you now. And again, the same sort of thing. You see it's around 10 hertz here and somewhere between about 0.1 to 4 hertz there. And then here's an older gentleman. Let's say this guy could be this guy's dad, and he still has a 10 hertz oscillation. It's a little bit weaker. And if you look at it, you see the band is shifted down a little bit. See, it goes from about 8 to 12, and then this guy here goes from about 10 to 15. That's actually pretty normal. We actually see that, that sort of shifting. I'll show you another figure of that in just a second. You see he has a slow delta oscillation as well. Now here's someone who's 81 years of age. And this is a woman I took care of who had a tumor on her chest wall that was the size of American football, and it took the thoracic surgeons the better part of 6 hours plus to remove it. And you can see she has very, very weak alpha oscillation, also very weak slow oscillation. This is what we typically see with aging. And the other thing too, which also lets you know that she's unconscious, is there's a total absence of any sort of oscillations up here. And so this is on a dB scale. So going from here to here is something like about 45 dB. So she has a drop here, which is at least about 25 dB. So she has nothing happening in her cognitive in the spectrum of where her cognitive rhythms sit. So we feel very comfortable she's unconscious. But the one thing which is really critical about this particular case is that I was able to give her 1/3 of the already age-adjusted dose of propofol during the case to keep her unconscious because I was watching her EEG. So I was able to wake her up on a dime. I didn't overdose her. And that's one of the key benefits of actually using the EEG to take care of patients, because you can titrate your dose of anesthetic, certainly the drugs intended to produce unconsciousness, much more precisely. Now here's the thing that's a little bit sobering. These two guys are the same age. His EEG looks like his, and his EEG looks like hers. When you see this at first, you think, wow, what's going on here? But then when you think about it, we age different physically. Our brains age differently too. And I think that's become a major theme that we see both in the scientific literature and the popular literature, realizing that this is the case. But what's interesting is that maybe some of these things can be brought out under anesthesia. And I don't know per se that he has an older brain. I'm just referring to that way because it looks more like hers, and his looks more like his. So this is a very, and if you ask why would something like this come out under anesthesia, well, forget about anesthesia for the purposes of giving someone drugs so that they could have surgery. Think of this as a neuroscience experiment. What we're going to do is we're going to put in a stimulus, which is going to generate oscillations. So you have a nice young brain, you generate very vigorous oscillations. As your brain gets older, it's less able to generate those vigorous oscillations. They become weaker and weaker. And the rate at which that happens, or the sort of degradation in the oscillations, really depends on how well we've been treating ourselves. You can guess what the kids look like. So there's a 3-year-old and there's a 14-year-old. So you see they have the same patterns basically across the age groups, but the spectral bands are much broader here in the 3-year-old and the 14-year-old. And then the low frequency power is much greater. So there's a very regular way in which this happens across age. And in fact, Shun pointed this out. The actual peak of where this the power and the spectrum is actually around 6 to 8 years of age, and after that it declines, very, very sort of systematically. And then the 81-year-old was sort of sitting somewhere out here. And just to make this point a little bit more precisely, here's looking at this over age. We put together a spectrogram. I should say Patrick Purdy, my colleague, put together a spectrogram of patients as a function of age. And you can see here's the young folks here as we're getting a little older, a little older, a little older. And you see now as you get into the 70s, you see the drop out of the alpha oscillation, and then the slow oscillation sort of becoming becoming weaker. And it turns out that these areas that are associated with producing the alpha oscillations are many of the same areas that show, aging, and also in some cases show overlap with, Alzheimer's disease. So in other words, so this is an expected, it sort of would be an expected type of change, given what I told you about the oscillations in the area of the brains that are the area of the brain that's producing them, the areas of the brain that are producing them, and what we'd expect to happen with time. And one final thing, here's a very young person. So kids who are like 0 to 3 months of age don't have any alpha oscillations whatsoever. And we think that's because the thalamocortical connections haven't formed. But then as soon as something magical happens at 4 months of age, you start seeing the alpha oscillation. And and we think that this is because the thalamocortical connections have now formed in a way that you can actually see the communication response to the propofol. We haven't studied that in detail or documented it, but this seems very, very reasonable given the development of the connections between the thalamus and the cortex. And then one final issue I just want to point out to you: the oscillations change very dramatically with age. Excuse me, with patients, not age, but patients' state of health. And so this is a gentleman here whose lungs are whited out because he has COVID. All right. And he's got rip-roaring inflammation, infection throughout his body, and particularly in his lungs. He has ARDS, adult respiratory distress syndrome. And if you look at his oscillations, see his alpha oscillations have disappeared. But now once he starts to get better, like over here on day 3, his lungs are almost completely cleared up. His alpha oscillation returns. So this is something that we had projected would happen, but we had never seen it before. And this is one of the things we were able to observe during COVID. So inflammation is a very potent factor which can affect the oscillations. And inflammation can help turn the brain off. And because it actually binds, the inflammatory mediators bind to the areas in the brainstem and actually inactivate them. So that's consistent with us, feeling sort of sleepy or groggy whenever we have some sort of infection or which might be associated with inflammation. This has been documented by Mark Gott, who's a neuroscientist at University of Washington in Seattle. So in other words, the inflammatory state of the brain or the state of the patient's health can also affect the quality of oscillations that you see. So all these factors have to be taken into account: drug, the age of the patient, and also state of health when interpreting the EEG. So let's talk a little bit about the future. So, there's a lot of talk now about using AI in medicine. And this, I think, is one of the first sort of low-level ways in which this could be done. So Suresh Chakrabarty is one of our former postdocs, and Jake Downing, I mentioned before, was one of our graduate students, built a control system to control the anesthetic state of a non-human primate. We had done this about 10 years ago in rodents, and the FDA said to have approval, we'd have to eventually show it in non-human primates, like animals which were much closer to humans. So they built a simple control system. So how does this work? So you have a marker that you want to control. So you put it at a certain level. And then you can actually read what the marker is from the EEG directly, or the local field potential that it's going to be in this particular case, because it's going to be from electrodes inside the monkey's brain. And then based on the difference between where the target is here and where you want it to be, you're going to see the infusion rate of the pump change. So the pump is sending propofol into the non-human primate at a certain rate, and we update that rate. The rate is continuous, but we change it every 20 seconds based on what this difference is. And so this is a very standard sort of closed loop system. So let me just show you what it looks like. So what Suresh did, he set the marker. It should be at 1. We know that this would be profound unconsciousness if the marker is held at 1. So what we're going to do first is not let the controller work. We're going to just run a constant infusion of the propofol. And the reason we want to do this is because this is what's done in the operating room now. You just run constant infusions. You don't have control systems that help you control the delivery of the anesthetic. And so, and I'll just play it for you. And then we're going to show you what happens when the control takes over. So there's you can see the marker. It should be at 1, but it's wandering all over creation because the infusion rate in the middle panel is just constant. Now the controller comes on here, right there, and now it locks it in at 1, right where it's supposed to be. All right, it's holding it. It's doing the control. It's keeping the level of unconsciousness precisely where we want it to be. Now we're going to take it a little bit deeper, and the time on the x-axis is in minutes. Take it a little bit deeper, right? And it's holding it right where it needs to be. And then what we're going to do is we're going to take it a little bit, make it a little bit lighter, above where we were before, a little bit above 1. And the controller is able to do that and hold it basically right where we want it to be. I want to show you something back here in the beginning, which is very relevant for clinical practice. You see this part of the experiment here? Constant rate, this is the OR, this is what happens in the OR now. And look what happens with the constant rate, patients just get deeper, 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 right? And what did the control system do? It actually turned the propofol off for about 2 to 3 minutes in order to get back up to the level where it needed to be. And over here, you can see it actually turned it off for about 8 minutes or so in order to get back up to the level where it needs to be. So clearly a computer can watch the brain better than we can as anesthesiologists. We can watch it every 20 seconds or every 5 seconds. And so this is something we're working quite diligently on now to sort of bring into clinical trials. And so the last idea is reanimation after general anesthesia. This is my colleague, Ken Soll. And below is a letter to the editor that was written after an article the New York Times did on us a few years back. And this person said, I had my first corrective surgery due to infantile paralysis in 1949, so that's polio. The bill for the anesthesiologist was $400. My mother was horrified, but my father calmed her when he said it was probably $50 for the procedure, but I gladly paid the $350 because he knew how to wake her up. Right? You know, people tell me, oh, you're an anesthesiologist, you knock people out. I say, yeah. Any fool can knock you out. We bring you back. Now, what happens is we don't actually give you drugs to bring you back. We just let the drugs wear off. And so Ken has been studying ways to actually wake patients up from anesthesia. So here he is testing it out on a rat, and I'll explain this to you. I'll just play the video. So the rat is anesthetized with isoflurane, one of the ether anesthetics again. And he's been there for about 20 minutes or so. Ken's going to inject Ritalin, the same Ritalin that we give children to treat ADHD, right? He injects it in and he has to flush it through. So it actually gets into the animal. He has an IV in his tail vein, so he flushes it in with normal saline. And we didn't turn the anesthesia off, so you can actually see that something's happening already to sort of bring him to. Now he has to turn over for this to Ken. You can see whatever he got is profoundly affecting his level of arousal. So he's going to try to flip himself over. He's going to have a little bit of difficulty because his feet are caught in the wires there. He has to really give it a good push. He does make it. I've seen the end of the video. A couple more times, guy. You can do it. Come on. Come on. A little more. One more. Okay. He got it. All right. Fantastic. So what is Ken doing? So Ken is giving Ritalin. So what does Ritalin do? It blocks the it blocks the reuptake of dopamine sort of in this major pathway here. This sort of meso, meaning midbrain, cortical pathway. So it starts here in the midbrain. This is the ventral tegmental area. And it goes through, this is the limbic system, which involves the amygdala, which is associated with emotion, hippocampus, important for short-term memory, and the nucleus accumbens, which is also associated with emotional affect. And it's blocking the reuptake, so there's more dopamine in this particular pathway. And this is the pathway where Ritalin is sort of used to help treat kids with ADHD. And Ken has also done this by injecting directly, stimulating electrically to turn the VTA on, and also stimulating optogenetically to turn the VTA on. And he's shown that if you activate the D1 neurons there, you can wake the animal up from anesthesia. So some sort of drug in this class, whether it's Ritalin or maybe one of the amphetamines or something, will start to be hopefully coming to practice in the next few years as a way to help turn the brain back on and help reduce the high prevalence that we see of brain dysfunction after anesthesia, particularly for elderly patients. So what have I shown you? Again, my main theme is the brain is Under general anesthesia, dynamic is not turned off. I've shown you that one of the primary mechanisms in which the drugs work create altered states of arousal by inducing and sustaining oscillations, which are quite different from the normal oscillations. They change in frequency and change in amplitude. You can use the oscillations to monitor the state of anesthesia using the EEG, and I showed you how they systematically change with anesthetic, the patient age, and state of health. And you can be using to develop a closed loop control system like I just showed you. And we should be actively thinking about turning the brain back on after general anesthesia. It may be a way to speed up recovery and reduce postoperative cognitive function. And general anesthesia is probably an underutilized paradigm for studying the brain. I'll just leave you with this little diagram here. So this is general anesthesia in the middle. This is the anesthesiologist's view of clinical neuroscience. Here we are in the middle, and all these things sort of circle around us. But it's really true that anesthesia has profound connections to all of these areas I've listed here. So we just mentioned depression and ketamine being used to treat depression. Ketamine was also used as a model for schizophrenia. And hibernation, the painted turtle actually induces a profound release and increases the sensitivity to GABA, and we can simulate that, with anesthetics. And the idea of coma recovery, what I was showing you there with waking the animal up from anesthesia. We also have a clinical trial. Brian Edlow, my colleague at Mass General Hospital in the neurology department, is using that same idea to try to wake patients up from coma. And we can use anesthetics to treat epilepsy. If you have intractable seizures, you actually administer anesthetics. You bring the patient into the hospital and actually anesthetize them to break up the seizures. It also turns out that at low doses, one of the drugs we might use to break up a seizure, methylhexatol, or one of the other synthetic opiate, alfentanil, is actually used to generate seizures in the operating room, so that the neurosurgeon can the seizure focus if he or she's having trouble doing that. So there are all these cool connections between all these phenomena in clinical neuroscience. And if we took more of a neuroscience view of anesthesia, we could benefit from what's being learned in these fields, and also these fields could learn from anesthesiology. And ultimately, the people who would benefit the most would be our patients. So I'll leave it at that. Thank you very much.
Thank you so much, Dr. Brown. That was a fascinating talk, very informative and very interesting. There are a couple of questions. So let me go ahead and ask a question from Agnesh Moshi. Could these waves stimulate the pituitary? For example, could it even affect growth of a tumor there?
The correct answer is I don't know, but nothing would surprise me, because these are very profound oscillations that affect basically all parts of the brain. So I wouldn't be surprised if it couldn't affect the pituitary, but I don't have any data on that.
Okay, there's a question from actually anonymous. When we sleep, we generally dream, and most times we remember the dream. What happens under anesthesia? Do patients have any dreamlike experience?
Okay, under general anesthesia, the way I defined it, meaning you're profoundly unconscious, you're profoundly unconscious. And actually, let me just go back here. I just want to show you this. We'll just go back and look at the oscillations, because I think this is a very important point. So if we go back here, so dreaming usually takes place in REM sleep, although there is some dreaming in non-REM states. So this is it's a near kind of awake state actually here with REM. Under anesthesia, you're profoundly unconscious, and in fact, you saw the neurons were shut down. They dropped their spike rates by 95% compared to being awake. So under general anesthesia, the way I've defined it here, the person would not they would not be dreaming. Now, what can happen is if you sedate someone where they're just sort of in and out of a light state of sedation, they could certainly have, dreams. They can maybe recall what's going on. But that's done on purpose, because you don't need to be under full general anesthesia to have like a procedure like a colonoscopy. So in that sense, in those situations, you could have dreaming or actual sort of remembering of things that transpired during the procedure.
Okay, thank you. The next question is also from Agnesh. Could the propofol induced state be achieved by other non-drug processes like deep meditation?
Deep meditation can certainly be used to help create these states. And I'll give you two examples. One, I had a colleague who used to basically do a bit of hypnosis on patients prior to surgery. And these are men who are coming in to have their AICD, their implanted defibrillators, changed or sort of checked out. And she used sort of a bit of hypnosis along with her drugs, and she was able to reduce the amount of drugs she was giving patients, and have these gentlemen wake up, very, very cleanly. In another situation, my colleague Bala Subramanian at the Beth Israel Deaconess Hospital actually has a meditation routine that he can take patients to. It's 12 minutes, and the effect of, again, reducing the amount of anesthesia that's basically necessary. And the third, actually, is the third one, an allegory from a colleague of mine whose grandfather was an anesthesiologist in India, and they were taking care of one of the yogis at one point, and he had an abdominal tumor, and they told him, we'll have to, put you under anesthesia to remove this. And he said, no, that's okay. You don't have to do that. I'll just go into a trance. And once I'm in the trance, just go ahead and do the operation, and then I'll bring myself out. And that's exactly what he did. So these mindfulness techniques can certainly help us out. And like I said, my colleague Bala Subramanian at the Deaconess Hospital in Boston, Beth Israel Deaconess Hospital in Boston, is actually studying them. So there's a lot of promise there.
Mm-hmm. Okay, thank you. There's a question from Mark Reimers. Have there been studies of cortical representations in different connected parts of the cortex during light anesthesia compared with waking?
There's been some work on that. I mean, it's not something that we've worked on because I guess for me personally, I want to get sort of anesthesia right. There's a lot of work to be done on just getting the basic, really making sure someone's unconscious, and then we meet all the other criteria in some sort of physiologically sound way that's readily reversible. And so I've thought myself a little bit less about some of these lighter states. The lighter states are intriguing because, they can mimic, like earlier question, like dreaming or maybe hallucinations or this sort of thing. And one of the things that happens, for example, like with ketamine and this dissociative state that it creates, even when patients are at the low dose where they're getting the therapy for depression, they can often hallucinate or go into a dissociative state where they can have even out-of-body experiences of that sort of thing. So those sorts of things they're known, they have been documented. It's not something that we're studying.
Mm-hmm. Okay. The next question is anonymous. I found it very interesting that alpha oscillations can be tied back to the thalamocortex oscillations. Do you think similar data could be used to infer other properties of brain connectivity and the relation to EEG measurements?
I really think so. So one thing you can do, and we've done this a bit with my colleague Patrick Purdon has done this, is measuring the EEG. And, just like with the MEG scan, you can have a forward model that gives a description of how the MEG signal propagates, meaning magnetoencephalogram, how the magnetic field signals propagate from parts in the brain out to the surface of the brain where you record it. And then using an inverse techniques, statistical techniques, you can then figure out, where the signal is being generated from. You can do the same thing with EEG. And Patrick has done work to sort of localize where the alpha oscillations, are coming from. I mean, that was part of that sort of segment that I showed where you had like thinning of various regions and what areas what might be responsible for that, and they overlap with the areas that are producing the alpha oscillations. So yes, you can do sort of this sort of inverse analysis, measuring what's on the surface, and then using that to infer what parts of the brain might be producing that and what the connectivity might be.
Mm-hmm. So another anonymous question, could brain damage occur if the patient is under anesthesia for too long?
Brain damage. I don't know if it's really brain damage, but let's say cognitive dysfunction it can certainly happen. And we see that, as I was saying before, in elderly patients quite frequently, and very often they're not in anesthesia for very long. we realize that, as we get older, our brains become frailer and sort of more susceptible to um, the effects of the anesthetic. So that's why it's important to basically titrate it. And if you think about it, on some level, these oscillations are not natural. You can see what the natural oscillations look like. They have these very small amplitudes, they're high frequency, and then the anesthetic oscillations have these very large amplitudes and lower frequencies. So you could really call them pathologic because they're not natural. So some degree of impairment should be expected. In other words, it shouldn't surprise us that people's brains don't work after anesthesia because we're using a unnatural phenomenon in order to control the brain. Now, we need these things for surgery, but it raises the question, is there some other way that we could do this where we wouldn't put patients through this type of
Mhm.
experience with the oscillations? And that's something which we're trying to think through and work on now.
Mhm. Okay, there's a question from Navin Alahari who asks, does alcohol also have a similar effect on brain activity as propofol?
Oh, it does. Alcohol is a very potent anesthetic. In fact, I've I've had um, I should say the privilege of anesthetizing someone who's acutely intoxicated, and you need just about 2 or 3 drops of propofol basically to sort of push them into profound unconsciousness. Yeah, alcohol is a very potent anesthetic. And, it, it, uh, it, it it's it's very effective. In fact, we did not need much to keep this gentleman anesthetized once we started him off on a little bit of propofol because the alcohol was working for us too.
Very interesting. So let's take 3 more questions and then we'll switch to offline mode. So Mark Reimers asks, are there any ways, techniques, or drugs to induce almost natural sleep in a confined, hence stressed animal?
Yeah, so the one anesthetic that I mentioned, going back here, um, let's see, I think it's here. Let me find. So this drug here, dexmedetomidine, comes as closest to producing something which is like natural sleep, the dexmedetomidine. So if you wanted to do an experiment like that, this is what it would administer because the way the dexmedetomidine works, looking over here, is a little bit complicated diagram, yeah, right here. It actually it disinhibits this part of the brain here called the preoptic area of the hypothalamus. And then these areas send inhibitory projections and sort of shut off the brainstem. This is one of the mechanisms through which sleep is initiated. All right. And so it's actually acting on this circuit that is also part of the initiation of sleep. So it would be the closest thing in our armamentarium that we have to something that approximates sleep. And now, just recently, there's been a oral form of dexmedetomidine that's been produced. It's for use for patients in the ICU. I suspect it's probably going to hit the market in the not too distant future as a sleep aid.
Okay, a question from Kyle Edwards. Can you speak a little more on the causes of post-anesthesia brain dysfunction and the mechanism by which treatments like Ritalin improve it?
Yeah, so so I think there are a number of things. I think that there are 2 components to it. First is you have, it happens most commonly in older patients, but I also should mention that 25% of kids who are given sevoflurane will also have delirium after anesthesia. And I think part of the reason that we see it is that you put the brain in a state of oscillations, a dynamical state. Let's say, think about it from the standpoint of dynamics, which is very far away from its normal state. And if you have a nice healthy brain, maybe it can relax back to the normal state more quickly. As the brain gets to be older, there's breakdown in connections, the myelin sheath is broken down, the cell volumes decline, the mitochondria don't work as well, the dendrites don't extend and retract as much as they used to, and also you don't produce as much neurotransmitter. So you're basically putting a very potent effect on a system where the wiring is quite old. It's as old as the person that you're taking care of. So it doesn't surprise me that this should occur. And again, remember, the oscillations are not natural. So what something like Ritalin would do, it would help maybe by giving an arousal signal to a part of the brain which is important for cognition, hopefully help restart the brain, basically. In other words, like right now, we don't do anything to restart it. We just let everything wear off and we just see what we have. And once you see how strong those oscillations are, it's not surprising you should expect people's brains not to work. In fact, I'm more impressed that some brains do work, or a good number of brains do work after anesthesia, given how strong the oscillations are. So the idea behind something like Ritalin would be to actually try to turn the circuits back on, as opposed to letting them come back on with their own time constant.
Okay. And then let's take the last question from Bill Robinson, who asks, do researchers experience these medications themselves to know what the experience is like for their patients?
Some of that might be illegal, so we have to be careful there. But I can tell you that one of my colleagues who were talking about this brain dysfunction, it really hit home with him when he actually had surgery, abdominal surgery. And he said, for like 2 months, I had trouble with like word finding. It was like wild. So those sorts of things, once you've experienced it yourself, you get a much more realistic understanding of what's going on. And it certainly, it would compel me, and it has already compelled me without even having experienced it, to try to come up with better techniques that would make this sort of get rid of this sort of dysfunction that's there. We now know we can take care of you under anesthesia, but now we should take care of you. Your brain should be the same brain that it was before the surgery. It should be the same one right after.
Yeah, that's great. Okay, let me then stop the recording at this